is Emily Johnson, and I will be the moderator for this week's ATI seminar. Before we begin, I'd like to do a land acknowledgement. So we acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. We'd also like to thank Palliative, Astellas, and AstraZeneca for their support of the ATI seminar series. And I have the pleasure of introducing this week's speaker, who is Dr. Puneeta Tandon. So Dr. Tandon is a professor of medicine here at the University of Alberta. She's also the director of the Cirrhosis Care Clinic, a transplant hepatologist, and lead of the Cirrhosis Care Alberta Quality Improvement Program. Her research interests include cirrhosis-related complications, exercise, nutrition and mental wellness therapy, and the use of digital technology as a knowledge translation tool. It is her career goal to provide holistic, interdisciplinary, evidence-based, patient-centered care through education, empowerment, engagement, and teamwork. And I will now hand it over to Dr. Tandon for her seminar titled Steps to Whole Person Wellness Along the Transplant Continuum.
Great. But super thrilled to be here. Thank you for attending, and we'll jump right into it. So my disclosures, I don't have any conflicts of interest, and I don't discuss any off-label use of drugs. I do hold research funds from several groups, all of which are paid directly to the U of A. And a declaration is that I am a hepatologist, and so I will have a cirrhosis-focused lens on all of this, but I think it is applicable across organ groups. So today we're going to talk about three main areas. One is physical frailty, the second is palliative care in transplantation, and the third, a little bit about mental health care needs and some research that we've been doing with the role of mind-body therapies. And I think this is timely in that I had the opportunity to be part of this initiative that was led by Lori and first authored by Sadie, who are on this call. And this was an attempt to come up with what, through ATI, our research priorities are in Alberta. So I had the opportunity to be part of Working Group 5, looking at long-term wellness. And I will say all of what I'm going to discuss today actually did get prioritized during our discussions. So let's start with physical frailty and prehabilitation. And you will be familiar, no doubt, with the fact that muscle health is actually a very important topic in transplantation. And there's several ways that muscle health manifests, whether it be sarcopenia, malnutrition, deconditioning, frailty, disability. All of these things have muscle being affected as an objective measure. And when we look at frailty, it's a geriatric construct. And so global frailty is defined as a clinical state of decreased physiologic reserve and resulting increased vulnerability to health stressors. In cirrhosis, we've most commonly studied the physical component. You can imagine if an individual comes in to hospital and they're physically robust, they are going to probably go down in their physical function during hospitalization, but they'll recover, bounce back to baseline. Whereas if an individual comes in already frail, they're down in their functional capacity, they're going to go down further into this zone of dependence, disability, and higher likelihood of mortality. There's various different tools to assess frailty, and they can range from really quick, easy to use ones like the clinical frailty scale, which take a minute, all the way to the most objective, which is cardiopulmonary exercise testing, which can be done as part of several pre-transplant workups. And the tests really across organ groups can vary. This was an American Society of Transplantation group that I had the opportunity to be a part of, where they looked at what are the different suggested tools by organ group. And you can see that they differ across the different groups, but the concepts are similar in how we assess these different domains of frailty. So let's get you engaged with the question. We don't just answer it in your head, but what do you think? In a meta-analysis of 1,100 patients awaiting liver transplantation, mean biological age being 55, what do you think their physiological age was by this gold standard frailty test, cardiopulmonary exercise testing? 80 years old. So we are dealing with very deconditioned individuals who are on the transplant waiting list, and I would say that this applies across organ systems. Now, flipping from frailty into sarcopenia, sarcopenia in the cirrhosis world has really been studied as a loss of muscle mass. In other geriatric, again, constructs, it is considered as a loss of muscle mass as well as function. But for this purposes, we'll be chatting about mass. So loss of muscle mass occurs in up to 70% of patients with cirrhosis. Prevalence is higher in men and in individuals with decompensated disease. As with the other organ groups, cross-sectional imaging for sarcopenia is the gold standard. And you can see very nicely here the red, more red on one scan than the other, the red representing muscle. There are cutoffs that are available that are associated with prognosis. And there's some heterogeneity, but they are all predictive of outcome. What's interesting is you can use these scans not only to look at mass, but other body composition measures. And this is a talk in itself, but other measures have been associated with worse prognosis as well, including how much fat infiltration there is into a muscle, what the fat actually looks like. So lower subcutaneous adipose tissue index, more visceral adipose tissue, and the morphological features of atrophy and inflammation, so the quality of the fat itself, have been associated with worse outcome. And hands down, all of these things are strong predictors of mortality, and I'll say they're potentially modifiable, which is why it's so powerful for us to be able to think about screening for these things. So let me show you data in cirrhosis again, looking at the liver frailty index. This is the most widely studied index that we use, which is a combination of hand grip strength, balance testing, and chair sit to stands. And this was an evaluation of over 1,000 adults on the transplant waiting list. Hazard ratio, if you're frail, increases mortality by about 2-fold on the pre-transplant waiting list. Similarly, this is 4,000 adults with cirrhosis who had sarcopenia. Those who had sarcopenia, hazard ratio, again, around that 2-fold increased risk of mortality. And if we look at malnutrition, that's variably defined, but again, 1,700 adult cirrhosis across 22 studies. Again, malnutrition increases your risk of death by about 2-fold. But it's not just the pre-transplant period, it's also post-transplant. And this is work in over 1,000 liver transplant recipients in the US, doing this liver frailty index again, and seeing that, again, post-liver transplant, your death risk of mortality increases by about 2-fold if you're frail going into transplant. Also, not surprisingly, length of stay increases, ICU length of time increases, and there's less home discharges. So what's driving all of the frailty, sarcopenia, and malnutrition? And there's multiple drivers, and these will vary obviously from organ system to organ system, but just going through it for cirrhosis, we know that it's driven by inflammatory milieu, so pro-inflammatory cytokines. Concomitant toxic pathogens can be damaging to the muscle, so like alcohol. In our patients, they have increased ammonia levels, and that is actually directly myotoxic. Common to see reduced testosterone across the organ systems, reduced physical activity time, reduced dietary intake, and specific to cirrhosis, they lose the capacity to store glycogen as well because of the reduction in liver function. And so they get an accelerated transition to starvation where they rely on their fat and muscle catabolism to liberate glucose. So digging into some of these drivers a little bit more, let's look at another question. So we did this, an analysis of 630 patients on our liver transplant waiting list now back in 2015. How many of them do you think met protein intake targets, which for us is 1.2 to 1.5 grams per kilogram per day? And it was 24% of them. So 24% of them met protein intake targets. But if you look at the lowest group, less than 0.8 grams per kilogram per day, what's important is that was an independent predictor of death, independent of their liver disease severity, their age, other predictive factors, something that is potentially modifiable that predicted their mortality. Now, with cirrhosis, we know that they can get reduced nutrient intake. And like I mentioned, related to inflammatory cytokines is in part, they have ascites, symptoms like nausea and fatigue. Again, these things we can do stuff about. Across organ systems, we have to ask about food insecurity, and this has become a regular part of my my clinical evaluation now. So asking patients whether they are actually able to afford food, and it's very unfortunate how common this is, not the case, that they're able to afford it. And then we certainly in the cirrhosis world put our patients on sodium restricted diets, and this is probably even worse in the kidney world. But we know that this impacts intake. And this was a study of 120 outpatients with cirrhosis and ascites. First off, only a third of them were adherent to the diet, but the adherent patients had 20% lower daily caloric intake. So we need to think about this when we are putting patients on special diets. How do we support them to get what they need in? I mentioned low physical activity, and indeed I just want to show you how low. So in cirrhosis, studies that have been done show that almost 80% of monitored waking time is sedentary. So again, another area of low-hanging fruit that we can try and impact. And many of our patients come into hospital, and that leads to a further deterioration. So they're often NPO after midnight for multiple procedures that may get delayed, and then more days of NPO. They our exercise teams on the wards try their best, but it's difficult to get to every patient. And so there's lack of standardized activity routines. And that leads to significant muscle mass loss. Now, I just want to show you this paper, which is an ICU paper, but I think just points out the dramatic muscle loss that can occur with being sedentary. And this looked at 63 ICU patients, mean age of 54. This first figure shows the change in cross-sectional area of the rectus femoris, so based on ultrasound. And you can see that the loss in muscle mass over 10 days was almost 20%. This study was beautiful in that it also did muscle biopsies as well, and you can see that the change from day 1 to day 7 was substantial. They're actually getting significant damage to the muscle. You're seeing reductions in the fiber cross-sectional area, and then obviously the DNA we would expect to stay the same, but reductions in the ratio of protein to DNA as well. So significant losses occurring. And in our individuals who have cirrhosis, they often come in with acute on chronic liver failure and multiple systems down. And this figure is nice in that it shows you with single organ failure, there's less loss in muscle as there would be in our individuals who are very sick, coming in with multi-organ failure who are at increased risk. Pulling in some of the other organ systems, the pathophys is similar. So this is looking at renal. We've got loss of amino acid and protein in the dialysate in PD, loss of amino acids during hemodialysis, got reduction in intake. We've got inflammation that's driven by gut dysbiosis. We've got metabolic acidosis, all of that leading to negative protein balance. With individuals with heart disease as well, we're looking at those same drivers. So anabolic catabolic imbalance, they get mitochondrial dysfunction, muscle fiber transformation, muscle infiltration, and similarly that myosteatosis that occurs, leading to sarcopenia, and then outcomes that are adverse. And then you've got lung disease as well, similar drivers, including the dyspnea and the hypoxia that then contribute to this reduction in protein accretion and sarcopenia. So with all of that picture of the fact that this is common, frailty, sarcopenia, muscle abnormalities are common, they lead to significant morbidity and mortality, they have a lot of drivers, some of them are potentially modifiable. What can we do? And I think there's things that we can do even at the individual level, but obviously if we have structured teams and support, then we can do a lot more. But I assure you, we can all in this room do something. We can begin by identifying the patient at risk. And this is from an ASLD guidance that we wrote for malnutrition and sarcopenia in individuals with cirrhosis. But here we have a little toolbox for how do you screen for malnutrition and how do you assess for frailty and sarcopenia. That's key as a first step. We need to be able to identify to be able to treat. Once we identify, then we can start interventions like prehabilitation. And prehabilitation, particularly for those individuals who are waiting for transplant, is essential. Surgery leads to significant physical, physiologic, cognitive, and psychosocial stresses. And what prehab is packaging how we can optimize function preoperatively to really enable individuals to maintain as much as possible a normal level of function. There's typically 3 or 4 pillars to prehabilitation, including exercise, nutrition, focusing on their mind, as well as healthy habits, things like quitting smoking, quitting alcohol, obtaining glycemic control. Now, when we do that, when we do the screening, we can target interventions, and this is a nice review that focuses on nutritional prehabilitation. And it was first authored by a PhD student in my lab, Christopher Cruz. And Chris has really nicely gone through how, based on your malnutrition risk, you get increased intensity of nutrition and personnel support, which can differ from program to program, but I would say a one-time visit with a dietitian is probably not enough for someone who really has severe malnutrition risk. And we need to think of it in this kind of structured way about the risk really feeding into how do we structure support. Similarly for exercise, this is from the American Society of Transplantation, again looking at individuals awaiting liver transplantation, but how a frailty assessment may guide what kind of prehabilitation and in particular exercise programming you give. So for a severely frail individual, that might look like inpatient rehabilitation as opposed to an individual who's just moderately frail who may be okay with home rehabilitation. And I'll just link you down to the bottom here, saying that we need to think about this not only in the pre-transplant period, but also in the post-transplant period. And this idea that there's a continuum across waitlist period, perioperative period, post-op period is something I think we all need to consider. And this was a review that we did back in last year, looking at frailty and sarcopenia interventions across the liver transplant continuum. So for nutrition in the waitlist period, we're really focusing on getting enough energy in, enough protein in, and timing the intervention so our individuals are not having long periods of starvation. In the immediate perioperative period, we're looking at things like enhanced recovery after surgery suggestions. So for example, carb loading or shorter preoperative fasting periods. Post-operatively, immediately looking at early feeding if there's no contraindications, and changing to parenteral route if the enteral route is contraindicated. And then in the longer post-operative period, what we're dealing with there is still important with frailty and sarcopenia, but there we're looking at how do we optimize body composition. So many of our patients will gain adipose tissue, and so we will need to try and shift that to increasing muscle mass and function to try and reduce post-transplant sarcopenic obesity and metabolic syndrome. Exercise, again, plays a role across the whole period. Combined endurance and resistance training. As I said, these individuals feel like and physiologically look like they're 80-year-olds. We need to ideally, if we have this available to us, involve certified exercise professionals. And then looking at them again from what I call a geriatric lens, recognizing what we're dealing with physiologically for really whole person care. So optimizing cognition, mental health, reducing polypharmacy, clarifying goals of care, as we'll get into. Looking at all of this across the transplant continuum is how I think we should approach frailty and sarcopenia interventions. So does this stuff work? Does nutrition and exercise work? And I'll show you one study. This was a study we did back in 2014, looking at the first RCT that was done in cirrhosis, actually, for exercise. So we're a little behind the game with cirrhosis and exercise in general, but catching up. And what did we find in this RCT? 19 adults were enrolled. Biological age was 57. We changed their VO2 in 8 weeks of them coming into the facility 2 times a week to bike by 5.3 mils per kg per minute. So what does that actually mean? That means we took them from feeling like 80-year-olds to feeling like 67-year-olds and looking like 67-year-olds. So not surprisingly, they had significant reductions in fatigue as well. Now, this study was an eye-opener for me because we did this in the supervised setting. We had individuals come in to do their biking, But what was remarkable was that there was a lot of people that we couldn't touch. And there was a lot of people we approached and they said, I can't travel in 2 or 3 times a week to do this. Or they were maybe having issues with confusion, or they lived in rural areas. So it was just impossible. And that really led us to thinking about how do we do this virtually and digitally so that we can help patients at a broader scale. And so I'm going to show you a video where we've involved patients to help us to develop an exercise and nutrition prehabilitation platform. And I will just play that on the next slide.
Find a comfortable chair, lift the leg.
Connie Serreras never thought she'd be a fitness model, but the 62-year-old was recruited for this video because of her health.
I was put on the transplant list in March of this year, so just waiting for a liver.
Connie is among 15 transplant patients volunteering to help create an exercise and nutrition app just for people like them. Physiotherapist John Ashmead says the workouts are designed to do at home, perfect for patients who live outside of major cities.
It allows them to make changes to their exercise program as they go along, that they can be in contact without having to be face-to-face with their clinician or their healthcare practitioner.
For Connie, leaving the house can be tough sometimes.
I think we take that for granted. I'll just jump in the car and go do this, and then you get to that point where you go, no, I don't have the energy to do that. I'm just going to stay home today.
But after waiting 8 months for a new liver, she wouldn't want to miss her precious opportunity, and she hopes anyone standing by for surgery can stay motivated too.
I think it's important that they, get out of their chair and get off the couch and try to stay as physical active as they can.
So that and several other research studies that we've done along the way has led to a CIHR-funded study looking at rehabilitation in individuals awaiting liver transplantation, which is actively recruiting now. And we've got multiple centers on board, where our hope is to randomize 177 individuals with a 2-to-1 allocation, and the primary efficacy endpoint is change in frailty over the period of time from baseline testing to end of study. Right now, just to give you a little bit of an idea of where we're at with this, so the study arms, they get access in the rehabilitation arm to the online platform. They get dietitian assessment and follow-up. They get protein powder supplied for 3 months. And they get access to an exercise trainer session once a week, in addition to their online exercises that they're doing. Usual Care gets emailed resources as well with this information about exercises and nutrition. To date, we've just got our site in Edmonton, as well as some Calgary participants coming in and some from Saskatchewan. But we're awaiting, hopefully this month, to have the Ontario sites live. And we've enrolled 37 participants to date, which is great. I can't obviously share any of the quantitative data, but we have been doing qualitative interviews with individuals, and just some quotes from them looking at improvement in protein intake, more energy, that they love the access to the dietitian and to the exercise specialist, good for motivation, that they liked the recipes, and that they thought the platform was fairly easy to use. So we will, hopefully I'll be able to come back with our final results alongside Chris, who's helping to lead this in the next year and a half or so. Okay, so we're going to flip from physical frailty to palliative care, which is another topic near and dear to my heart and to our research. And I would say, just a personal story here, what really inspired me with palliative care was actually the death of my mom back now 10 years back. And that was the first time that I really recognized how incredibly valuable this specialty is. And I must say I hadn't been exposed to it in the same way previous to that. But that got me thinking, how the heck do we get this out of just the cancer space and into our care of our patients who are living with non-cancer illnesses like cirrhosis. So I'm going to share another video, and this video is one that whenever I watch it, it really makes me want to be a better communicator and a better listener. And I think that's the core of palliative care. And so I think, we can do better probably at really picking up on symptom burden, and communicating with our patients and really understanding what they're going through. And again, this is cirrhosis related data, but our patients have a huge symptom burden on par with advanced malignancy. This is looking at 300 of our patients that we published on. Child-Pugh A, earlier disease, is yellow. Child-Pugh B or C, the orange, is more advanced disease. But you can see these bars are high across both the yellows and the oranges for anxiety, depression, pain, limited activity. Mean quality of life scores only 59 out of 100, huge stresses, and especially stresses with being on the transplant list. This is a study that looked at some experiences of being on the liver transplant list, and I think it's similar across sentiments across the other organ groups, but uncertainty related to life and death, really not sleeping well, thoughts buzzing around in their head, physical problems and discomfort during waiting, mostly sitting on a chair looking at newspapers, really become weaker, and then mental wear and tear, and this idea of bothering other people or asking for help to get everything done, and that the feelings that come with that of helplessness. And I just am so thankful for the caregivers that come into my office every clinic, because they take a lot of this toll on themselves. The caregiver burden in cirrhosis is comparable to Alzheimer's or advanced cancer studies. So from this particular study that was done in cirrhosis caregivers, 28% of them met criteria for depression, 39% for anxiety, and less than 50% reported that they had people to support them. So I think, thinking a little bit more about, can we ask, even asking, how are you doing? How are things going? That is a start. And we've historically not done really well with advanced care planning and palliative care referral in non-cancer illnesses. This is cirrhosis related data, but looking at rates of ACP and palliative care referral of about a third, if that. We know that from studies, patients listed for transplant actually have lower rates of palliative care consultation, with this idea that you can't do both together. And even patients delisted for transplant will sometimes have aggressive care and suboptimal symptom management. And this is data from a study looking at work that Dean Carvelis did now back in 2014, when 48% of patients were referred to ICU after delisting and 17% had renal replacement therapy still after delisting. I think this is shifting now. Other publications have showed that patients are referred to palliative care not very commonly, and that most of them, it's within that short window just before death. So it's really looked at as just those end of life care. And similarly, late hospice referral is common. Mean hospice stay being 29 days versus 59 days, and the majority of patients dying in hospital. And this is despite us knowing and having lots of data now to support that the early integration of palliative care works. It works to improve patient outcomes, it works to improve family outcomes, and improves process outcomes. So reductions in cost of care, reductions in admissions to ICU. So we know now from multiple studies that this is a no-brainer. So why isn't it happening? And I have a whole talk just on barriers, so I've just selected a few of them here. But I think one main one is that there's a misunderstanding of what palliative care actually means. And palliative care definitely means providing a good death at end of life, so avoiding distress and suffering. But it also means helping people to live a good quality life. Okay, and so this includes prevention and relief of suffering by early identification, treatment of pain and other problems from a whole person perspective, physical, psychosocial, spiritual. And really the core of palliative care is support. And that includes things like having conversations with patients about what direction is their disease heading, getting formal goals of care designations done and surrogate decision makers assigned, looking at symptom assessment and management. And we do this every day with our different organ systems that we deal with. I manage ascites all the time. That is providing care that's consistent with palliative principles. Needs assessments and care coordination. So thinking about functional status, maybe we need some help thinking about assisting with transitions like hospice, so getting palliative care, especially palliative care, involved with that. But at the core of it as well, I think, is effective communication skills. And if I could give you two take-homes for what palliative care messaging and maybe a shift in the way that you look at it, it's thinking of it broader than just end-of-life care. Palliative care really is something that can be initiated at the start of a diagnosis of a life-limiting condition, like all of our organ failure conditions. And secondly, we have a very small number of specialists who are actually in palliative care. And so palliative care doesn't just mean consulting a palliative care specialist, although there's obviously very good indications to do that as well. But we also need to take a role in starting to have these conversations, in managing symptoms, in thinking about caregivers. And that's called primary palliative care. We also really need to shift away from this idea that there's just curative and just palliative. Sometimes that is the case, but in transplant, I think it's this mix of both, where we're doing disease-modifying therapy. At the same time, we can be thinking about symptom management, making sure we're communicating with our patients, so really caring for them and their quality of life simultaneously. So second barrier that I'll point out is we're concerned about what patients are going to think if we refer them to a palliative care specialist. And this came up in this survey of 396 American Association of Study of the Liver Disease members. So the exact question there was, patients will be concerned they'll be abandoned by the liver transplant team if they're referred to palliative care. You can see the majority actually strongly agreed or somewhat agreed with that statement. What is the patient perspective on palliative care? And I thought this article was quite interesting. So they interviewed patients and they said, what do you think of palliative care? Before the term was actually explained, patients felt that you're at the end. They've given up hope. And then they explained to them, well, this is what palliative care actually is. It means providing patients with symptom relief, improving quality of life, and it can be provided alongside curative treatment. After it was explained, I wish I knew sooner, gives me hope. I didn't realize you can get it with a curative treatment. So again, this is all in a name and maybe these concepts that we have about what palliative care is, but when you actually explain to patients what it is, they want it. Let's go with one more question. So this was another study that we did out of our outpatient clinic, asking patients several questions. This was just one of them. But what proportion of people living with cirrhosis did you think wanted advanced care planning discussions to be done in clinic when they were stable, as opposed to when they were admitted to hospital? 84%. 84% of our 100 patients said that they wanted these discussions in clinic, not when the disease had progressed. And so this, again, I think we need to really listen to that and try and bring this into our clinics as much as possible. You may be thinking, okay, yeah, she's talking all about this stuff, but how the heck do I get started on this, or what can I do to maybe start? And I think there's room for all of us to make small steps in improving our communication skills. And I would say probably the first place to start would be recognizing that we're all skilled communicators, obviously, with all of the interactions that we have with patients, but I think we can do better. And we're probably more comfortable, as research has shown, discussing things like diagnoses and treatments and procedures, maybe less prepared to discuss dying, maintaining independence, impact on family. And so sometimes that can lead to prognostic uncertainty and vague terms, which leads to a tendency to overestimate outcome. And that can be challenging for patients who are making these difficult decisions. So I would say there's many things that you can do, and advanced care planning courses that you can do. The one that I have done is a serious illness conversation guide, which is offered through AHS. Literally takes half a day on a weekend and gives you a lot of value for that, with tested language that you can use. There's a script and some language that then you can practice with your patients. And it really is practicing. There's it's not going to be a script, but you learn with time how to adjust the conversations and how to make it work. The other thing I would really strongly recommend is a motivational interviewing course. And many of the skills are common. So learning how to ask open-ended questions, for example, learning how to listen is a big part of communicating. And so motivational interviewing, I had the opportunity to do a course through the Mayo Clinic, which was 6 months, but there is other courses that you can do for even a weekend that would help a lot. If you haven't heard of this, I would really strongly suggest looking at it. I had a YouTube video in here, but then the talk was getting too long. I love this best case, worst case scenario. It's a way to really frame choices for a patient in a way that they can understand in the context of their values, their goals, their preferences, and really using common language and stories so that they can understand better their choices and what they're actually asking to agree to. So again, I won't go into it much here, but you can Google best case, worst case scenario and YouTube video, and it's fantastic. What else can we do? We can have resources available. So speaking to cirrhosis, we've taken the time during our Cirrhosis Care Alberta Prius project to bring together experts in palliative care, hepatology, primary care, to say, how do we want as a province to manage these symptoms that are beyond just ascites and variceal bleeding and encephalopathy, but getting into how do we manage depression, pruritus, pain. And so these algorithms are available online at cirrhosiscare.ca. And Sarah Davison has taken it a step further. And so we're involved with her work here with One Care Path, which many of you may be familiar with, which is actually working on not only taking those recommendations for cirrhosis, but looking at heart failure, COPD, CKD, and cancer, and building these pathways in for primary care so that they have these algorithms and they can help to facilitate best quality care for our patients living with these chronic illnesses. And so to end this section, I really just want to end with the fact that I really strongly believe, and we've tried to make some inroads into this in the cirrhosis front, and we will continue to try, that palliative care plays a role in transplant. And I think it's all the way from assessment actually to transplant and even post-transplant. We need to work with our primary care and community specialists, and we need to obviously work with our patients and our caregivers to make this a reality. So this will be a goal of mine to help to continue to build. Now the last topic, and this is a shorter one, so we'll leave time for questions, is one of the main symptoms that often comes out when you do scores like the Edmonton Symptom Assessment Scale or the EQ5D is mental health burden, anxiety and depression, and high mental health care needs in the pre-transplant as well as in the post-transplant period. And I've just picked one systematic review to highlight, and this is looking at over 50,000 individuals who were awaiting transplantation, 27 studies, so heart, lung, liver, kidney, and other are all represented there. And they looked at depression and anxiety as risk factors for morbidity and mortality after organ transplant. Depression increased the relative risk of mortality, by 65% in the post-transplant period. Anxiety did not have as strong of an effect, but the risk was really unaffected by the type of transplant or other study characteristics. And there's many reasons why having impacted mental health can obviously impact your outcomes. It really does impair with the ability of individuals to follow along with treatment regimens, to be able to come in for follow-up, to have purpose in life. So addressing this is vital. In our particular research group, we're very interested in looking at digital health strategies. And so Emily, who did my kind introduction at the beginning, is a PhD student in our lab. And Emily is the first author on this publication, which is a systematic review looking at mind-body interventions that are delivered online in individuals with chronic physical conditions. So this goes beyond just transplantation. But looking at these 56 studies and these 7,000 patients, the effect size for these mind-body interventions delivered digitally was similar to pharmacological therapy. So again, something there that we can that we can use to help our patients. So over the last 5 years, we've been doing several studies looking at this mind-body wellness techniques, including mindful movements, things like chair exercises, some yoga, tai chi, breathwork practices, which can really help to calm the mind, meditation, sleep practices, and combining those with psychology-based programming using cognitive behavioral therapy or acceptance and commitment therapy. So really looking at topics like pacing, managing thoughts, self-compassion, managing feelings. How do you build a village, bring people together? So these kinds of topics are what come up in our programming. And then at the request of our patients, what's been added in as well is disease education. So specific tips every week for their particular condition that they can learn from experts such as yourselves around living with their chronic disease that they have or their post-transplant state. And we've also heard from our patients that community is very important. And so we do have aspects of community in our research studies that we've done so far using the digital platform. I'll just show you this one slide. This is one of our randomized controlled trials in chronic liver disease, just to show you that this is 87 participants in this particular condition. It affects predominantly women. It's primary biliary cholangitis. So the majority were women in this study. You can see impact on mental health measured by the hospital anxiety and depression scale. We're looking at like 20% improvements in the total scale, 26% improvements in depression scores. And in those who do the program at least 3 times a week, looking at 46% improvement in depression scores, and lots of quotes from patients as well. So on the next slide, I'm just going to show you one short video of a few patients who have provided some feedback, and we've actually done about 60 or 65 interviews so far. And we've just picked a few quotes from there. So I'll show you that from this Empower study is right here. So this Empower study is ongoing. We're recruiting into it. It's CIHR funded as well. Recruitment will finish in the next 3 months. And we've randomized, I believe, 650 participants so far, but there's room. We're trying to get up to 850. There are specific programs for individuals living with cirrhosis, chronic kidney disease, heart failure, and those who are post-transplant. The post-transplant, I think, is our second largest group right now. So absolutely reach out to me if you want more information about this. We've got cards you can hand out in your clinics, and this is the website for the program. The next slide is the patients speaking about this, and then I'll do my final slide and we can go to questions.
The breath work gives me the proper way to breathe easily in times of when you are, say, stressed, or when you are like resting. If you want to rest like fully, it helps you a lot. And like I said before, like during the time that I can hardly breathe, I think about those things, and it helps me a lot.
Definitely, it improved my mental states, not only for the physical activity or for being to do it together with my wife, but also because like I said, the breathing and the meditation, I think, did a change in my emotional state.
And the breath work is amazing. Like I had never considered it before. Now I can use deep breathing or belly breaths to put myself to sleep.
And my point of view, those little videos regards of the psychology, they are good because they are short. They have I call them very nutritious, and because they are very brief, but like I said, very substantious, they get an impact. That's true. Click.
And I'm pretty sure, like this program will help a lot of. But the core of the program is the breath work and the meditation. That's 100%.
Now, I don't know why necessarily, but it changed my life, and it's got to be because it made me stronger. It made me healthier. It made me happier.
For everybody, because of the way the intensity of the program is. It's for people who have like low mobility to a higher mobility, to the highest mobility.
I can't say enough about it. I so appreciate it because I am like night and day. It's great.
So with that, we've gone on a little journey for 3 areas. And with my motivational interviewing health coach hat on, I would encourage you to think about one small change you can make next week from this talk. And I really think we all do need to move closer to whole person care. So is it talking to your patients about the importance of nutrition and exercise? Is it thinking about starting advanced care planning discussions early? Even if it's just seeing palliative care in a new light, that would be a big win. I would encourage you to sign up for motivational interviewing or the Serious Illness Conversation Guide Advanced Care Planning course, and absolutely reach out to me to enroll your patients in Empower. We've only got 3 months to go, and we'd love to have more patients in there. Last slide, thank you to everyone I work with. This work is not done by myself, and I have incredible students and other researchers that I work with, and of course the patients. And thank you to my family as well.
That was really excellent, Dr. Tandon. Thank you so much. In terms of the reach, a lot of your patients work was done in liver. How extensive is the interest and uptake amongst other organ groups as well in Calgary and Edmonton? Because it looks like you were doing interviews in both.
Are you talking about for the mental wellness program?
Yeah.
Yeah, actually, Emily might be able to answer that better. I do think, well, it's a virtual study, so essentially anyone can enroll. Emily, do you know whether there's a reach outside of?
Yeah, we've got people from North America and into Europe and Asia. So there's a little bit of everything, but the majority obviously comes from the Edmonton program. And it looks like Lori has her hand raised. So if you want to go ahead, Lori.
Yeah, that was really terrific. I really enjoyed that, Puneeta. And I was sort of thinking of the same questions maybe that Sean was asking, is it the different organ transplant groups, and also thinking of some of the work that Michael Corey is doing in the pediatric heart, for example, but the different things that encompass all aspects of wellness and support for that. Including exercise, but also all these other supportive things. Is there work being done in heart and liver and similar work to this?
I don't know if anyone's on the call for answering that specifically in heart. But I do know when we were at ATI rounds last year, there was certainly interest in expanding some of this work into the other organ systems and even into pediatrics, saying that there is a big gap. So I think that's a huge need actually across organ systems, and somewhere where we can ideally, with those ATI priorities, actually work together to build on synergies and build something very strong that can help to support our patients.
Thank you. And again, congratulations. Wonderful talk. Great work.
Thanks, Lori.